I'm Sue Janik, President of the League of Women Voters of Dane County. Welcome to our forum, Healthcare Going Forward in Dane County and Wisconsin. The League of Women Voters is a political, nonpartisan organization. This means that we do not support or oppose candidates or parties, but we do advocate for our positions on many issues, including healthcare. We, of course, support access to affordable, quality healthcare. In response to the constitutional crisis facing our country, the U.S. League of Women Voters developed a program called Unite and Rise to mobilize the population to defend our democracy. In Dane County, you may have seen us. We've been attending rallies, holding sign making and postcard parties, and educating our community about important issues. Yesterday, the Wisconsin State Journal published our letter opposing efforts to require voters to prove that they are citizens. There's a pledge that you can sign, a Unite and Rise pledge, and we encourage you to do that to show that you support this work. Many of our members volunteer their time and money to carry out our mission. Our end-of-year fund appeal is right now in full swing, so please consider making a donation. I want to thank those who volunteered to plan tonight's forum. I'll just read through names quickly. Rebecca Dane, Carol Colby, Ann Lacey, Janine Ramsey, and Marty Stamper, our program director. And also thanks to those who are helping out tonight: Joy Cardine, Annette Zarnecki, Helen Petracki, Manasi Prashant, Sarah Punt, Richard Russell, and Tigan. And our tech support, John Steffen and Julia Gilden. Thanks to all of them for donating their time. Finally, I'm going to make some announcements that you'll be seeing on the slides, but I just want to mention some important things coming up. On November 6th, there will be a post-forum discussion on Zoom starting at 7 o'clock. And that will discuss the issues that are raised in the forum tonight. On November 19th, we're having a no RSVP lunch. That means you just show up if you feel like it. And that will be at the Cozy Nook Cafe in Cottage Grove. I don't know where it is, but it must be near here. On December 2nd, which is Giving Tuesday, we'll be having our holiday soiree and a civics trivia game. And that will be at the Delta Beer Lab, where we can drink beer also and eat pizza and socialize with each other. That'll be starting at 5 o'clock. In mid-January, there will be a forum on disinformation that will be held on Zoom only. We're not going to try to make people risk coming to an in-person forum in January. And on March 19th, we're having a fundraiser with the theme Spring into Democracy that will be at the East Side Club starting at 5:30. Our land acknowledgement statement will be presented by Joy Cardine. Joy is a retired talk show host, former member of the League of Women Voters of Wisconsin board, and recipient of our Defender of Democracy Award in 2024. Joy.
Thank you, Sue. It's my honor to be here. League formation began more than a century ago in 1920 with women's suffrage, but nearly 2 centuries ago, even prior to the 1848 creation of the state of Wisconsin, an 1832 treaty forced the Ho-Chunk to cede their territory of Dajob, or Four Lakes. Both the federal and state governments repeatedly but unsuccessfully sought to forcibly remove the Ho-Chunk from Wisconsin. Truth and acknowledgement are critical to building mutual respect and connections across all barriers of heritage and difference. We continue this effort to acknowledge what has been buried by honoring the truth. In Dane County, we are all standing on the stolen ancestral lands of the Ho-Chunk people. We pay respect to their elders, past, present, and future. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together today. The League of Women Voters of Dane County is grateful for the past, present, and future guidance of Wisconsin's Native nations. And now it's my pleasure to introduce my friend and colleague, Carol Colby, our moderator tonight. An experienced broadcaster and moderator, league member Carol Colby has had an extensive career in communications, most recently as executive producer and host of the long-running radio program All About Living, and moderator of the cable television program Picture of Health for UW Health. Very apropos for tonight. So please welcome with me, Carol Colby.
Thank you so much, Joy, and thank you everybody for attending, whether in person or virtually. We really appreciate you being here at the League of Women Voters of Dane County's Public Forum, Healthcare, Going Forward in Dane County and Wisconsin. I am Carol Colby and particularly pleased to be moderating tonight's forum. In addition to being a League of Women Voters member and volunteer, my earlier graduate work at UW-Madison focused on women and health. And for over 25 years, I covered healthcare issues in the broadcast media. Throughout this lengthy journey, it became clear to me that we are privileged to have excellent healthcare resources available. But if people don't have access to them, they will not experience the benefits to their own health that our highly trained medical professionals and institutions can provide. The reality is, at some point in everyone's lives, they will need health care. In the recently passed federal legislation known as the One Big Beautiful Bill Act, issues of decreased access, affordability, and insurance coverage have been raised. How these will play out in Dane County, in Wisconsin, and in the country as a whole are still somewhat of a moving target. But tonight, with the help of our esteemed panel of experts, we will attempt to clear up as much as possible and give you the current facts on healthcare moving forward in Dane County and Wisconsin. Our first speaker is Jason Stein, president of the Wisconsin Policy Forum, who will explain the statistical impact of the federal legislation on public health care programs. Jason has worked with the Wisconsin Policy Forum since 2018, serving as president since July of 2024, and prior to that as vice president and research director. His reports have received multiple awards from the Governmental Research Association. His recent work on federal funding cuts and the state budget discusses the potential impact to Medicaid in particular and to healthcare more generally. Jason previously was a Capitol reporter for the Milwaukee Journal Sentinel and the Wisconsin State Journal. So please join me now in welcoming Jason Stein.
Well, hi, everybody. Thanks for having me. Thank you, Carol, for that nice introduction. The Wisconsin Policy Forum is more than 100 years old. It was formed by the merger of two longstanding organizations in the state in 2018. We don't advocate or take positions for or against issues. We just try and give you information so you make up your own mind better. Our supporters include nonprofits, local governments, school districts, higher education, institutions and individuals. So, if any of you have interests as individuals or, as part of a larger employer in the area, you can always reach out to me and we'd be happy to have you join us. So as I think about the issues that we wanted to talk about, for the first couple slides that I have are on the spending nationally, federal spending at both the US and the local government level. Just to provide some context, Wisconsin has always lagged in receiving federal funding and has always lagged the rest of the country in terms of the net benefit between what we receive from the federal government minus what we pay in taxes. If you look at federal spending in the most recent year, from statistics that we have from the Rockefeller Institute, there was about $16,600 average across the country and about $14,700 averaged in Wisconsin. So just to give you a sense about how we lag. In addition, as we think about where is this spending concentrated, it's mainly concentrated in the subject areas that we're talking about tonight, mainly healthcare. So if you think about in Wisconsin, Social Security is roughly a $30 billion a year program. Medicare is roughly a $12 billion a year program, something like that. Medicaid is about $8 billion. So if you think about that, what does that mean? Well, you just do the math on that. A 1% cut to Medicaid in Wisconsin would be, in the neighborhood of $80 million on an annual basis. Medicaid, for those of you who are not familiar, is both covers low-income individuals, both in terms of acute and preventative care, as well as long-term care. As we think about what's happening nationally, one piece of context that I always provide when we're talking about federal funding cuts and some of the potential impacts of federal funding cuts is to note that we do operate in a system right now where the federal government is running a significant annual deficit and has significant debt that is building up over time. And to note that right now, we're still seeing higher, at least in the figures that we were able to examine over the summer, we're still seeing higher year-to-date spending by the federal government than we'd seen in prior years. Why is that? In part because some of the main programs like Social Security and Medicare are not being touched right now by funding cuts you see at the federal level. And although there are going to be significant funding cuts to Medicaid, those won't kick in until 2027 in the main bulk. So as I look now, I wanted to give you also a little bit of background about how Wisconsin is one of 10 states nationally that has not expanded Medicaid under the terms of the Affordable Care Act. Most of those other states are in the South. The Wisconsin Policy Forum did a report on Medicaid expansion in September of 2024. All of the research that I'm showing you here is available for free on our website, and you can check it out at wispolicyforum.org. But these are some figures that came out of that. Just to explain, when we talk about expanding Medicaid for the federal, under the terms of the Affordable Care Act, what we're talking about is taking the maximum income level for coverage up from 100% of the federal poverty limit to 138%. So you can see there what the numbers are for a family of four. 100% of federal poverty would be just a little over 31,000, whereas 138% of federal poverty would be about 43,000. Much less if you're looking at just an individual. And these, by the way, are figures for 2024. So the ones for 2025 be a little bit higher, but not much. Okay, so one thing to know about Wisconsin is we are really, when it comes to Medicaid, an outlier state. you look there, the states in gray are the states that have expanded Medicaid under the Affordable Care Act. They're covering adults up to 138% of the federal poverty level. The slide we have here looks at parents. So Wisconsin is the light blue state, and then the other states that have not expanded Medicaid are the dark blue states. So, those states are generally well below the poverty limit in terms of what they cover for people. Wisconsin has partially expanded its program and covers parents up to 100% of the federal poverty level. We also cover childless adults, adults without a dependent child at home, up to 100% of the federal poverty level. These other dark blue states are really different. If this slide was for childless adults, all the gray states would look the same. Wisconsin, the light blue state, would look the same, but all those dark blue states would be zero. There would be no coverage for childless adults in those states. And that's one reason why the BBB is going to affect us, even though in terms of some key changes like work requirements, even though Wisconsin never expanded Medicaid fully under the Affordable Care Act, we still do provide that coverage to childless adults. And that is where some of the big changes in the bill happen. So the Big Beautiful Bill Act, which I always have a little bit of a hang up on that. That's it's something is either a bill or an act, but never mind. It is estimated that it would reduce Medicaid spending nationally by $900 billion over 10 years, according to the Congressional Budget Office. It's a range of changes that are going to lead to that impact, but one of the biggest ones, and I think the most pertinent for discussion with just, ordinary citizens, is the work requirements that will take effect in January of 2027. Those will require adults without dependent children, ages 19 to 64, to work, volunteer, or attend school for 80 hours a week. There's been estimates that change certain other ones, and we'll talk about in a second, at the end of 2025 of enhanced tax credits under the Affordable Care Act in the private insurance markets could lead to 270,000 people in Wisconsin losing their health insurance over the next decade. I think, I'm giving you that estimate because the best estimate we have. In all fairness, we really don't know how these work requirements are going to play out in the state. The reason we don't know is that we just have very limited experience with those ever being implemented in Medicaid. Only one, and I'll talk about that in just a second. But another major provision of the law is it repealed expansion incentives. So there were incentives in the Affordable Care Act, that were passed as part of the American Rescue Plan Act that would have delivered more than $1 billion in one-time funds to Wisconsin if we would have expanded Medicaid, and many states that did receive those funds. Wisconsin will no longer be able to do that because of the provisions of the bill. I'll just try and move along now. The work requirements, most of the people who they would apply to in Wisconsin already, and who are on Medicaid without disabilities, already work, about more than 2/3 of them. We don't know a lot about how these requirements would impact other states. One example of a state that implemented them for just a short period of time, a few months, Arkansas, saw significant decreases in Medicaid enrollment because of that. However, again, in 2027, we don't know who the governor will be in Wisconsin. We don't really know the federal rules that will apply. So it's a lot of uncertainty about how that would play out in the state. I'll just try and keep us moving. One other major change that's affecting public healthcare programs in the state recently is the state budget, just with literally hours to spare, expanded or increased the hospital tax in Wisconsin, the BBB put a limit on how much that tax could be increased going forward. And so Republican lawmakers and our Democratic governor signed legislation with just hours to spare that increased that assessment from 1.8% of gross patient revenue to 6%. That will net the state, we estimate on an annual basis, about $1 billion. It will draw down additional federal matching funds, and that will allow the state both to increase payments to hospitals by more than an estimate of more than $900 million a year, and provide some additional money that the state will hold on to run the Medicaid program. However, because of the way the provisions in this federal law, if we ever expanded Medicaid going forward, we would need to reduce that tax. So that really changes the calculus about whether Wisconsin would expand Medicaid going forward to something that's quite different from when we published our report about a year ago. All right, a couple slides here to end. At the end of this year, we will see the expiration of federal tax credits that are available in most Affordable Care Act plans. These credits were approved under Democratic control of the federal government in 2021. That means that essentially there's a certain cost of coverage for individuals that are in these healthcare marketplaces under the ACA. With these subsidies going down, these individual consumers will have to cover more of their healthcare costs. The amount of the increase that they could see at the beginning of 2026 is really going to vary. Silver plan premiums could rise from $727 to a little under $2,400, according to the state commissioner of insurance office in Dane County. You'd see a smaller increase, but still a significant one for young adults. In many other counties around the state, you'll actually see these increases at larger levels. So because in Dane County, we have a relatively competitive healthcare marketplace for both insurers and providers. And here's, I believe, my last slide. I just wanted to make a note with what's happening in the federal government shutdown, that there's also significant changes being made to the food share program. I won't go into all of them, so I don't go over my time, but just to draw you back to how important some of these programs are. Right now, as some of you may be aware, there's questions about whether people who are receiving food share benefits in the state, which is the successor to the food stamps program, it's known now as the Supplemental Nutritional Assistance Program at the federal level. Just 1 month, if those benefits aren't delivered in Wisconsin because of the shutdown, would be roughly $115 million. So it's a significant program in the state, and one that could compound some of the impacts that we would see if people's health insurance premiums also rise. And so with that, I will, yield the floor to others, and certainly be available to answer questions later on in the program if you have.
I'm sure there will be questions. And speaking of that, while it's still fresh in your mind, there are so many moving parts to this. If this happens, then this won't happen. If this won't happen, then this will happen. While they're fresh, please write your questions down and pass them to the volunteers. And we will get into our next speaker and address those questions at the end of the 3 presentations. Our next speaker is Shiva Badar, who will speak to us on accessibility challenges in healthcare. Shiva is a leader and effective champion for social media and belonging at the individual, organizational, and community levels. She has been working on issues related to health disparities for over 30 years. Shiva served as an alder on the City of Madison Common Council from 2009 to 2021. She co-chairs the Latino Health Council of Dane County and is a member of the Access Community Health Center Board. She has also served on the Governor's Health Equity Committee. Shiva's many accolades include receiving the 2010 City of Madison Dane County Martin Luther King Jr. Humanitarian Award, and the 2018 Visionary Award from Centro Hispano of Dane County. So please join me in welcoming Shiva Bedard.
Thank you so much, Carol, for the kind introduction. Again, thank you so much for having me here. I do want to say, just so that it's there, that I am not representing my employer. I'm really representing, kind of my work, my passion, and my expertise around health equity and health disparities, which really are going to be pretty clearly glaring as we kind of see how the changes in access and coverage unfold. Again, many unknowns, but still kind of a bit of clarity, I think, around the fact that there is going to be disparate impact. Why? Because there always is disparate impact on communities who have had for a long time been underserved, not included in ways that really focus on access and delivery of healthcare. So if we look at healthcare in general, we already know that there is clear disparities based on racial and ethnic groups. So Black in Wisconsin, Southeast Asian, Latina, Native American, Indigenous. There's certainly, and you'll hear much more about that from Jeremy, disparities when we talk about rural versus urban, and of course, socioeconomic status, and then clear also disparities that impact people based on their LGBTQIA2S plus identities. So we already know, and I could go on about those and tell you every area, but trust me on saying that if you look at any area of outcomes of healthcare, we already see disparities. And one of the things that the expansion of ability to have access to insurance with the Affordable Care Act did is actually to have a way for us to better address those disparities. Why? Because it creates actually access, and the first thing that you need to create better outcomes of health, that you have access to healthcare. So when we think again overall about health insurance in all of its category, whether it's Medicaid, Medicare, or Affordable Care Act, really at its foundation is about creating the first step into improving health and health outcomes, which is having access to it at an affordable, in an affordable way. So now, and you certainly, if you want to ask me questions around some of the disparities, I'll leave that to the questions. But in Wisconsin, just overall, just so we have a sense of like current state of insurance, we have about 6.5% of our population, more or less, I think, give and take, were uninsured part of the year, and about 3.5 uninsured the entire year. So pretty good, right? Dane County, 94.2% of adults between 19 and 64 years currently have health insurance. So again, pretty good. The highest population that is uninsured, and I say uninsurable, is the Latina population. That is true in the state of Wisconsin, in Dane County, and across the US. And the reason is because of the limitations to access any of these programs, Medicaid, Medicare, and Affordable Care Act, that have existed for a long time based on immigration status. I say that because there is some facts. So first fact check is that there is conversation about like, oh, all this is discussion is because undocumented immigrants are getting access to Medicaid and Affordable Care Act, and we need to end that, right? So fact check is that undocumented immigrants have never qualified for Medicare, or Affordable Care Act, with one exception, which is called emergency Medicaid. Emergency Medicaid is limited to life-threatening, acute medical need, and labor and delivery. So, those the fact that there is kind of this conversation that really brings this immigration issue into the healthcare access issue, checking the facts are important. That said, many of the changes that are being proposed, or at least we're foreseeing are going to be implemented at this point, actually impact immigrant groups that have had access to some form of coverage up to now. So I'm gonna name a few of them. I know it's going to be like mind-boggling for those of you who don't do immigration stuff all day long, but it will give you a sense of how much the details matter, right? And how different populations get impacted. So, for example, for Medicaid, for federal Medicaid, what is being proposed right now, as of October of 2026, it will be only limited to people who are legal permanent residents of the United States. So these are people that are known as green card holders. Cuban and Haitian entrants and COFA migrants. So don't ask me about COFA migrants, but I'm just going to tell you that these are people that are from Micronesia, Palau, and the Marshall Islands. They have their own category under immigration, so that are living in the United States. So that's all. Meaning that many of the other categories of immigrants that we see on a regular basis in a process to legal permanent residence or in other processes such as refugees, asylum seekers, women who are applying for a U visa under the Violence Against Women's Act, survivors of human trafficking, people with temporary status are not either currently eligible or definitely not going to be eligible in the future, okay? So really think about all of these categories of individuals. Same is true for Affordable Care Act. Again, Affordable Care Act has been traditionally actually the marketplace has allowed the broadest category of immigrants to be able to have access to buying in the marketplace. And that is also being proposed as being limited to a much smaller number of immigrant categories. So one that I will just mention is that DACA, Deferred Action for Childhood Arrival, which are otherwise also oftentimes known as the Dreamers, which are children who arrive in the US under the age of 16 with their parents as undocumented, and have a category under an executive order by President Obama in 2012. They were actually excluded specifically from being able to buy in the marketplace in the Affordable Care Act when the law was passed. It was part of a negotiation to exclude them and many other categories of immigrants actually from accessing the marketplace, with or without subsidy, not even like in the subsidy conversation, just not able to even pay full without subsidy. They were added to be able to have coverage under the Biden administration in the last year of his administration. So they were able to get coverage this year for the first time ever, and then that's been eliminated again. So again, impacts on real, populations that otherwise are not able to in any way or shape have access to insurance. So Medicaid is also and Medicare are interesting because even when we talk about legal permanent residence, there is a 5-year wait. And the 5-year wait for legal permanent residents to be able to have full access to Medicare or Medicaid after they gained that status was actually part of the Welfare Act under President Clinton. So that's how far back it goes. So continued again, erosion into different groups that can not have access. So a few things I want to just also mention about the Affordable Care Act subsidies, and maybe, for some of you, this is a reiteration of what you know. Some of it Jason did mention, but I think important to kind of like really digest some of this information. So we talk about the enhanced subsidies. So again, defining what these are. So the enhanced premium tax credits were temporarily expanded under ARPA, right? So it was kind of under the COVID, post-COVID, kind of trying to support recovery. They were set to expire, of course, we all know that, I think by now, at the end of 2025. So what they were doing is that there were subsidies for 100% to 400% of federal poverty level. And these enhancements were put in place in 2021 to provide additional subsidies for people in the 100 to 400%, and then also extended the subsidy to people that were above that 400% poverty guidelines. if you looked at kind of the chart that was provided by Jason on federal poverty level, and if you haven't looked at that lately, just go, and Google, and you'll see what 100% is for a family of four. Is really, really low. So when we talk about 400%, I think sometimes in people's mind is like, well, they sure can afford this, right? Like it's people who are making 400% of the federal poverty level. It's still, especially I would say, I think everybody here probably lives in Dane County, right? So we all know what rent and property looks like. So it would be really important to really think about that 400% and above, and not people who are making actually a lot of money. Yes, probably what we would consider the middle class in our kind of environment. So the other things that are also going to diminish access that we haven't mentioned is open enrollment periods. So making open enrollment period for Affordable Care Act shorter than it has been, starting in 2027. The last piece, and I know I just have a few minutes left, so I'll move to the last piece of what I wanted to mention. Oh, and then as I was talking about health disparities and how we create these health disparities, so the requirements for providing additional paperwork in proving, your hours of work, whether you have worked these 80 hours, et cetera, all of those things, really what they create at the end of the day is barriers that reduce access. Because we know that in the majority of cases, this could be the same people that may have less digital literacy to be able to upload, maybe even if we get to the uploading the documents into complex, portal systems, may not have access to those documents readily, have difficulty getting their workplace to provide them things. So again, it just creates barriers to being able to apply and continue to have insurance through, again, Medicaid, Medicare, or Marketplace. Last thing that I wanted to mention is that regardless of the changes that happen to your insurance coverage, people, I think you said it, at some point, everybody needs access to healthcare in our lifetime. We do have an Emergency Medical Treatment and Active Labor Act in the United States. This was passed in 1986 under the Reagan administration. Just like to mention it because you can see how these issues have been part of, every administration. So it was passed there, and it was passed under COBRA, which was the Consolidated Omnibus Budget Reconciliation Act. And it requires that all hospitals, really all hospitals that receive Medicaid funding, but you'll be hard pressed to find a hospital that doesn't receive a Medicaid funding, to provide emergency stabilizing treatment for anybody walking in, no question asked, regardless of anything, whether it's your citizenship, whether it's your ability to pay, any of it. So it's really been a really important point of access. So important to know that's going to continue to exist, but I think at the same time to know that that's great, but one, emergency care should not be the way that we access care unless it's really needed to be emergency care. It's high cost care, and the cost needs to then be actually somehow still paid by everybody. Right, so it actually ends up really creating ways in which we're directing people to emergency care because they cannot have insurance that allows them the right access and the right point of access, increases costs for everybody. And so that's the last piece I would say also is that I think there is some predictions about increasing costs of your insurance that you get through your employer too, right? Because if there are more uninsured people, higher cost of healthcare, that cost needs to be equalized across. So thank you so much. I know I'm out of time. 1 minute, that was good. Never be the person that gets like taken off the stage. So I'm gonna leave.
I can't imagine doing that, Chief. Thank you so very much. Again, I'm sure that stimulated many thoughts. As we said, everybody is going to need health care at some point, so how are they going to attain it? as all of these changes are coming forth. Our final speaker is Jeremy Levin, who is the Director of Advocacy at the Rural Wisconsin Health Cooperative. Jeremy has been with the cooperative since 2008, advocating at both the state and federal levels of government in the area of health policy for their network of rural hospitals. Prior to this, Jeremy spent 5 years advocating for physicians at the Wisconsin Medical Society. He also worked in the Wisconsin State Legislature and served on the Dane County Board. Jeremy serves as a member of the Wisconsin Hospital Association's Council on Public Policy and the Council on Rural Health. He also is a member of the Children's Health Alliance of the Wisconsin Advisory Board, the Immunize Wisconsin Advisory Board, and the National Rural Health Association's Board of Trustees. So please join me in welcoming Jeremy Levin, who will speak to us on healthcare turmoil in rural Wisconsin.
Thank you, Carol, and thank you to my other presenters. It's a privilege to be up here, and I'll let you know a little bit. The Rural Wisconsin Health Cooperative was founded in 1979. As Carol mentioned, we are a network of 40 rural hospitals throughout Wisconsin, which is probably about a little more than half of what you would consider rural hospitals. And when you see one rural hospital, you've seen one rural hospital. Half of our members are affiliated with or owned by a larger health system, and half are what we would call sort of freestanding independents. In fact, there is one freestanding independent with Stoughton Health in Dane County and is a member of the co-op. For a long time, I would say Wisconsin was in a stronger, and I still would say that rural Wisconsin hospitals are in a stronger position than those across the country. You may have heard oftentimes on the news about hospital closures across the country, primarily really in the south and southwest part of the country. But that hit home in 2024 when 2 hospitals as part of the HSHS system in Chippewa Valley closed. And a large part of that was sort of a disparity in the amount of public payer. So unfortunately, when hospitals financing, a lot of it comes through, especially in rural areas, Medicare is usually your largest payer. Medicaid is then sometimes next, and then you'll see more of the commercial and employee-sponsored coverage. Rural health and rural populations tend to be older, sicker, poorer, actually have quite a large amount of Medicaid as well, as obviously very urban areas. And so, you know, when we also talk about different populations that, you know, may not or may fall through the cracks or may be subject to not being able to qualify for healthcare, publicly funded, would be potentially your agricultural workers. You know, and then you also have a different system through a lot of the Native American through the National Health, Native American Health Service. So there are different models, obviously. I think what we've seen a lot, and again, in some of the items that Jason brought up, you know, Wisconsin for rural healthcare and healthcare in general has been a little bit stronger for obviously not being an expansion state. We do go up to the 100% of federal poverty level. And then from there, those who are above 100% can go straight into the healthcare exchange and be eligible for those subsidies. And so that will obviously cause a lot of problems. And just to, you know, take that home a little bit more, I know Shiva and Jason have talked about it a lot too. So like ACA enrollment in Wisconsin in 2020 was about roughly 195,000. When those enhanced premium tax credits began in 2021, the enrollment as of 2024 was 266,000. So quite a dramatic increase. And for a large part, that was based upon those premiums. And we talked about a lot with sort of the KFF numbers. And Shiva made a point too of, 400% of federal poverty level might sound like a lot, but when you think of a couple 60-year-olds, so not eligible for Medicare yet, 400% of federal poverty level is roughly $82,000 or $82,000. So in looking at some of those KFF numbers, so around the second, and I have more numbers broken down by congressional district. So Dane County, we're in the second congressional district, roughly an annual increase of $16,000 in premiums when these subsidies and credits go away. The largest two congressional districts in the state, the third, which is sort of along the western part of the state, and the seventh congressional district, which is more north and northwest, would see an annual increase of almost $23,000. So a couple making, again, $82,000 doesn't have that much stocked away, I'm sure. That is something that I know is obviously, as we sit here today on, I think, the 35th, 36th day of government shutdown, and it's something that is being debated in Washington, or not always being debated in Washington. But government shutdown also has a large impact on rural healthcare, on a couple of extender programs. So unfortunately, rural healthcare, as you can imagine, is more spread out, lower populations, which then mean lower volumes in your hospitals. A lot of how government and healthcare functions is more on sort of the higher volumes that you would see around your more urban centers. So there are these programs. One is called the Medicare Dependent Hospital payment. One is also called Low Volume Adjustment payment. Both of those expired with the shutdown. Also, a lot of the telehealth waivers that we saw, again, rural healthcare spread across a larger geographic area. Telehealth waivers also expired before, at the end of the last federal fiscal year, and were not extended yet. But there is bipartisan support, but again, it requires actually passing some legislation to expand that. Jason mentioned sort of the state budget, and it was a very quick and it was amazing in my 25 years of working in sort of politics, advocacy. I've never seen a state budget and a federal budget so intertwined. And I guess, federal budget, but the OBBB. And it was very positive to get Wisconsin and our policymakers in a bipartisan fashion to increase, again, the tax on hospitals. So again, this is funds that come from hospitals to go through a program that the federal government has created and is perfectly legal, despite what you might hear from certain politicians and leaders. But it is something that puts, I think, Wisconsin at least in a stronger footing moving forward when we have a lot of unknowns that are coming up, again, with the expiration of the enhanced premium tax credits, and in 2027 with cuts for Medicaid that we will be seeing. The OBBB did include some specific funds for rural health. One of that you may have heard is the Rural Health Transformation Program. Actually, applications to those are done at the state level, so state governments are the ones applying, and they're due actually tomorrow. I think Wisconsin was hoping to submit ours today, so I have a feeling they did. That is $50 billion, and that sounds, wow, $50 billion sounds like a lot even amongst 50 states. Well, again, KFF estimated somewhere between about 137 to 155 billion being cut from rural healthcare. So the 50 billion is roughly a third, and making that back. And it will also be interesting to see it isn't just going to rural hospitals or just rural clinics. There are some broader instances and ideas that could potentially qualify. So it will also be interesting to see how those funds get disseminated through rural healthcare. And that's a concern, definitely. I think other concerns, Shiva named it too with EMTALA, the fact that just because you are uninsured doesn't mean you are not able to get health care. I mean, hospitals will be there, and they're there, 24/7, 365. So it's one of those things when then the hospital's bad debt or charity care increases, that affects the rest of the healthcare system, and that will also affect what those of us who have private insurance, whether through our employers or through the marketplace, it will affect those costs. And also problems that we're seeing in rural healthcare. We are seeing, again, an older population. Our workforce is older. So again, we have a lot of doctors and other providers that are retiring, and in healthcare, it's one thing because they walk out the door one day as an employee and they walk right back in the door the next day as a patient. So healthcare is definitely needed. And so what we're seeing, a lot of the stressors on rural healthcare, workforce is definitely one of them. We also see stressors from dealing with insurance companies and payers in general. Those are definitely items that continue, and I'm sure again you catch in the news every once in a while when so-and-so health system isn't working with a certain insurance carrier, and then everyone there is out of network and they have to potentially go seek care somewhere else, and that's very disruptive to anyone. And again, in rural areas where transportation may be harder to get to that next hospital or the next county or so over, where your insurance might be good and or allow you to be in network, or again, you're just having to change plans, which again, there are also less plans usually in rural areas. So as Jason mentioned, Dane County is very competitive. A number of counties, even just outside of Dane County, will see less carriers. So I think I got 5 minutes, so I'm going to give 5 more minutes to questions, but I really appreciate the time and effort that the League of Women Voters has allowed me to take. So thank you.
Well, thank you very much, Jeremy. And I think, do you all have your mics there to answer questions? If I just may interject on the last point about the rural healthcare, are you seeing closures? Even though there's distances between access, are you seeing closures of clinics or doctors' facilities or hospitals that are going to affect access?
It's on. Oh, yeah, okay, great. We're seeing, I don't think we're gonna see the closures that we saw in 2024. I mean, that was a wake-up call, frankly, but more of a shock. You will see, obviously, their clinics could revolve around almost, solo practitioners. So someone may decide to get out of healthcare or they're retiring. You're seeing a lot of stress on more service lines. So the hospital will have to, they will be having pressures from the financial that they're seeing, and so they will have to sometimes make tough choices. We've seen more OB line or units close in Wisconsin in the last couple of years. I want to say there's been like 16 different units that have closed since about 2023. And it's interesting, again, I do a lot of work nationally as well, and they show a lot more other states that are really OB deserts. But like Wisconsin and Minnesota have actually lost more service and units, but that we were just blessed with more. So it's definitely stress that's coming on oftentimes those services that are really under reimbursed too. That's what we're seeing both on OB, behavioral health. I mean, these are services that just sometimes reach a breaking point. And that's just the hospital having to make tough choices of, do you keep doors open for potentially your primary care and some other services within the And you also have issues too with getting necessary providers in those service
Right.
lines as well.
Must be frustrating for the providers, for medical profession and for patients. Well, I just allowed you to use a little bit of the 5 minutes that you didn't. So thank you. I see that you are continuing to pass questions, and I know that there are questions coming in on our Q&A box. So we're going to move into some of your questions now. We'll get through as many as possible before the time comes that we must end this forum. And there are 2 questions that have come through. It's like on both sides of the issue. So I'll kind of tie them together. They're rather huge. Oh, one other question, comment. You have mentioned, several of you, the KFF. And just for clarification, that represents the Kaiser Family Foundation. It's often a resource or a source that you will see when you see statistics on healthcare. And it's a highly regarded and reputable source. So when you hear or see KFF, it's the Kaiser Family Foundation. All right, this question, the increase in premiums is shocking when the tax credits expire. How can anyone afford a few $1,000s extra a month for healthcare premiums? Won't this mean many will just go without insurance? And what are the consequences of that? And then on the other side of it, and so maybe you can address both aspects, what is being done about the exorbitant cost of healthcare? I mean, the premiums represent paying for healthcare. The cost is unsustainable. Healthcare insurance costs are rising annually and more than the rate of inflation, and it's now at a high rate, 18.51 of American GDP. These costs cannot be sustained. What can be done about this? Are there efforts being put forth to analyze why healthcare costs so much? So, Jason?
Well, there's a lot there.
Yes, that's what I said.
I'll just say at the beginning, I mean, clearly there's going to be an impact of the credits diminishing as significantly as they are. And Jeremy spoke to how much the Affordable Care Act exchanges, how much their enrollment has risen in recent years. And that's due in large part to the tax credit increases that took effect in 2021. And so we're gonna, I think, pretty clearly give back some of that enrollment. You know, we'll see to what degree. And that means, you know, there may be certain cases where people go on to much less favorable plans. There may be other cases where people have just go to no coverage at all. And when you think about who drops coverage, well, the people who are going to be most likely to drop coverage are going to be the people who need it the least, and the people who are going to be most likely to dig deep and find some way to afford their coverage are going to be the people who need it the most, and who are those people where they're going to tend to be older and sicker. So then the insurance, the pools that the insurers are responsible for are going to become less, more expensive. And so that's gonna be, also put upward pressure on premiums. We'll see if that leads to more uncompensated care or uninsured care, bad debt at providers. That may also then have some impact on, people in other, people in private insurance and other forms of coverage who, because ultimately, as Sheila said, the hospital has got to pay its bills in one way or another. If it remains open, it's gonna have to do that. It's a totally different discussion that I'm probably not the best person to address about all the healthcare cost drivers. I will say that although we definitely need to control healthcare costs, and we also need to preserve healthcare access, it's nevertheless and probably our most important priority, besides perhaps the education of the young. Healthcare is our number one. I think health is our number one priority for ourselves and our loved ones. So I will just, always put that caveat that it's not necessarily money that's badly spent, but at the same time, there also needs to be all our other needs and priorities addressed.
Shiva, do you have anything?
No, I was just gonna add that in the priority, be housing, education and health, right? So again, as we think about like just expenses in general as a society, I think, that's where kind of the three foundations, should be. The issue is again about, who pays for it, right? And who has access to it. And then I think what all our expectations are, or what we have access to, and I was just reflecting about coming back from visiting a hospital in Mexico over the weekend, and just very different expectations about what we all expect. I think in this country, from going to, a hospital and what the facilities can look like.
I don't want to put you on the spot, but is there anything that you can share with us about your experience visiting that hospital in Mexico that ties in a little bit, or in contrast to our situation here?
I think the contrast is the ease of access, in the sense that there is not this kind of, we're talking about all these categories of insurance and Medicaid and Medicare, and do you have this and that? And then we have EMTALA, clearly. I think everything there looks more like EMTALA, right? Like you access, and then there is like, is there potentially a form of payment or not? But the expectation really is that it is a public healthcare, the one I went to. Of course, there's private clinics, I don't take me like, but there are public healthcare systems. Is not ideal in the sense that there is, of course, a lot more need than there is space in the hospital. So not actually, that's similar to what we have, because we haven't even talked about the fact that there is just a lot of demand for healthcare. Because of the aging population and, many other reasons. But it's hospitals that really do provide that kind of point of entrance and access. But the physical environment and facilities certainly look very, very different than ours. Meaning, for example, 3 patients in a room, a pediatric NICU is 10 kids in one room. That's very small. And access to all of the certainly latest equipment and medication looks very, very different. But as far as like kind of that basic access to healthcare, it's there. And OB for them is of course a high priority, right? So there is OB in every hospital, even in the smallest rural hospitals, which is very different than what we see happening with OB access, labor and delivery access in Wisconsin, especially across the country, but in rural areas.
Thank you, Jeremy.
Yeah, just I agree with Shiva that housing, education, and healthcare are really some of those basic tenets and needs that folks have. I think Jason did a very good job of describing what we oftentimes call sort of that insurance death spiral. And it's just, did it with, I guess, a nicer name. I think what we've seen oftentimes with sort of increased healthcare inflation that we have experienced, it did unfortunately come about a lot because of the pandemic. I mean, we saw a lot of staffing issues. We saw people sort of getting out of healthcare, and it was the cost of staffing. I mean, hospitals, usually about 60% of your cost is just your staff, and those are people, and those are jobs. And so it's both good and bad because it costs, but those are also, good family supporting jobs. And I think what we're also seeing is a lot of inflation that happens with just supplies. And we have other problems with potential tariffs that are causing some inflations too with medical supplies. And that is something that is oftentimes not, believe me, I hear a lot from our rural hospital members. I mean, they don't have a whole lot of control when it comes to the supplies that they need or the staff that they need. Oftentimes, staff of highly educated and skilled providers can be even more expensive in rural areas than it is in suburban and urban.
Since you have the mic, let me ask you this question regarding rural healthcare. What are the bottlenecks in rural healthcare that can be fixed? We have new technology, we have AI. We talked about telehealth, which is going away, but it sounds like it's in discussion, behind closed doors. What are the things that could be interjected into rural healthcare that would solve some of the access and affordability issues?
I mean, I don't think telehealth's going away. I mean, it's obviously something that, again, expanded through the pandemic. I think people have gotten more comfortable too with telehealth. It is a necessity to, you see, problems though, is how does someone get maybe the bandwidth to also have that telehealth even into their homes or, remote patient monitoring. It still requires having that broadband to get the coverage and the monitoring to, say, the hospital. Transportation is often a cost that is probably borne more in rural areas. Oftentimes too, it's problematic for a family member to take off time from their jobs with transportation. I think getting, and again, what the legislature did with the budget to try to increase, and hopefully we'll see more increases in Medicaid rates. I mean, that some of those are incredibly low, and even though there was an increase of, anywhere from about, that hospitals will see from about $750 to $900 million, it is still about what was half of the shortfall that Medicaid was paying or underpaying the cost to provide care to providers. So it's not going to be, I think, a perfect fix. Again, as I said, I think we're in a stronger footing as we go into a very uncertain time.
Jason, I have a question for you. What is the impact of the LWVDC, the big beautiful bill on Medicare, if any? And are there direct costs, indirect costs that are in the bill or that we can project?
I haven't looked deeply at Medicare in the forums studies state and local issues, and Medicare is an exclusively federal program. But in general, Medicare has been partitioned off from a lot of what we're seeing. I think to the extent we're going to see significant changes for that program, some of them would just be in the realm of indirect impacts of, if there are, for people who are on Medicare, it's more about, is there still a hospital that's open in their area? Is it still providing the range of services that it did before? Are the costs within that hospital or provider network rising because of, uncompensated care or other things? So, I mean, I think those would be some of the big ways we can see that. And, I don't know if Jeremy might be able to speak to that as well, just thinking about how that might play out in a rural context.
I mean, I'll just go again back on my thing. There has already been cuts in Medicare that impacted immigrant population that went into effect actually immediately for any new applicants. So they reduced kind of the categories of who can qualify for Medicare, which again went into effect immediately this summer. And then what they're doing is for the current enrollees, then there is a delay, won't be into effect until January 4th of 2027. So new people who were previously qualifying cannot enroll anymore. People who were qualifying under those categories can stay on them, but that will end in January of 2027. So, there is some, pretty big estimates of the number of people across the country that can impact, and most of whom, again, are people who potentially also have disabilities and certainly other needs.
You have the microphone, so let me ask you a question that has come directly to you. Shiva, how has the downturn in hiring physicians affected patient care? In particular, how can medical centers deal with this as international doctors are facing difficulties with visas?
Another.
Got your attention.
And that's a really, really important conversation, which is around H-1B visas which are work visas, right? So I think people have heard that there's kind of new requirements and barriers into being able to get those work visas. Still in play, I would say, because there is a lot of advocacy that's being done to try to at least have a carve out for physicians, many of whom are rural physicians. Many of those physicians actually come on those visas to work in rural areas in this country, including in Wisconsin. So there is still some conversations that are happening to try to advocate for having an exemption of that $100,000 that the employer would have to pay, which, as you can imagine, would just not be something that can be done at any kind of scale. And to kind of prevent some of the additional barriers that are being put in place. So, but it would, again, it would have a very, very direct impact on all healthcare specialties and subspecialties where those individuals are really like, you know, recruited because they can provide really some specialty areas into academic medical centers, but I would say also very much so in rural areas.
Is that, I just to
So,
clarify.
I mean, I think, you know, you said to call for action, so this is one of those issues that are very specific, right? That you can contact whomever you want to contact and say, we really need this workforce in this country because they're providing healthcare that otherwise we don't have the workforce to provide.
That would be probably our elected officials because they are making the decisions. Just to clarify, it hasn't been mandated yet that the $100,000 visas for physicians or for medical personnel.
No,
Okay.
I mean, there's still a lot to be sort of announced on that. I mean, it isn't affecting those who are currently on H-1Bs, and that affects more than physicians. Oftentimes physicians will actually come through J-1s, it's nurses, it's pharmacists. I mean, so there's a lot more, again, than just physicians within a rural hospital. You know, what, again, it does, you hear more and more drip out. You know, it's not those who are currently on H-1Bs, and it may not affect those through certain professions, and healthcare may be exempt, but I think what it causes is a lot of uncertainty, and probably also reduces the attractiveness of trying to come here and be a healthcare provider if you're a foreign graduate or foreign national.
Here's a question for any one of you, and can you comment on the nonprofit hospital systems? What does that mean, and are they complying with requirements to provide uncompensated care?
Well,
No.
I mean, nonprofit, I think, is, and how the vast majority of Wisconsin hospitals are formed. Nonprofit, you are then putting back any additional revenue profit back into the enterprise. And so, again, as I talked about how coming out of COVID, the workforce has contracted, and also rates and salaries have gone up. That's being where you're seeing a lot of what you might otherwise say is your margin being put back into the enterprise of the system. But, you know, there are other healthcare facilities in this state that are for profit, that might have a backing on private equity, and those then see their profits go to shareholders. So it's, I think nonprofit is definitely the way to go. All of our 40 members are nonprofit, and again, serving their communities the best way they know how.
Did you have a comment?
No.
No, okay. Well, speaking of profits, can you address insurance company profits and their impact on healthcare costs? I read that major insurance CEOs took home $150 $160 million in compensation last year. Any comment on that? And then do we have
I
any?
can say insurance companies are usually not a non-for-profit.
And- Okay, let's see. Well, how will, and then a little bit more explanation, Shiva, on the uncompensated care, or those who are the immigrants who really are undocumented and can't get care. How will that work? Is it all going to be dependent on EMTALA, or what
Well, we've,
creativity is being explored?
so that's not it. So the reason I brought that back, because providing care to undocumented immigrants is not a new issue, nor have, it's been an issue, it's been something that, that again, different nonprofit healthcare organizations have done for a long time. So there are certain things that are, EMTALA said, because EMTALA is not a source of payment. EMTALA is providing the care, and again, it's only emergency, stabilizing care and labor and delivery. So I think you will see, and this was actually also something that was a requirement of the Affordable Care Act, was that every nonprofit hospital had to do, have to have very clear process for their financial assistance program. And that information needs to be publicly facing, explaining what is that hospital doing to provide financial assistance to those who are either uninsured or underinsured, by the way. And so those processes have been put in place. I think that was a really kind of a positive thing that also came out of the Affordable Care Act, so that there was transparency in what the process is. Most hospitals across the country provide that care to, again, uninsured, uninsurable, and underinsured individuals, and have a qualification process that goes up to certain percent of federal poverty level. So we've already been doing it, but I think what I think it's when you're tipping the balance of having more people join the roles of uninsured, then you just are increasing that need, right? Right now, we know that need is very much oftentimes focused on those who are uninsurable, which again, could be because of their immigration status. So by increasing the need for uncompensated care, as I said, you're just gonna pass on the cost some other way. I mean, hospital, or you're gonna close hospitals, one or the other, is going to happen, because it is not sustainable for hospitals to provide, a high level of uncompensated care. Hospitals already don't get paid to cover all their costs by Medicaid and Medicare.
And isn't the emergency room treatment under EMTALA, it's for the condition that you come into the emergency
It's
room for? Just
That and even for that is for stabilizing, so whatever that means. If you come for a headache, it may be like just making sure the headache is taken care of. If you come for something that is much more emergent than that, it doesn't mean that you're gonna get the full treat under EMTALA. I'm not saying a hospital is not gonna do that, but like if you come and you're diagnosed with something that needs follow-up care, EMTALA doesn't certainly mandate anything outside that emergency stabilization. Most hospitals and nonprofit will do what they need to do to care for a patient
right.
above, way above and beyond EMTALA, I would say. At
Is-
least I would say, at least I know in Dane County, in our state, I know our healthcare systems all do way above and beyond EMTALA.
There's a part two to the question asking that of you, Jeremy. Are you noticing that is a huge issue in rural hospitals? And also, there's a question, what constitutes a rural hospital versus an urban hospital?
Honestly, usually the best way of figuring out rural versus urban is just sort of reimbursement methodology. Oftentimes, I mentioned a couple of the what we call extender programs that are sort of in limbo now because they expired at the last fiscal year. There are also 58 critical access hospitals within Wisconsin, and those also get reimbursed slightly differently, again, to try to make up for the low volumes. Urban hospitals are what we call the prospective payment system, and pays based on codes and groupers, and do a little bit better in just the economies of scale and a larger volume. I'm sorry, what was the other part of the question that they wanted?
Oh,
for
what,
rural?
what is the definition of a rural hospital versus an urban
Oh,
hospital?
I thought I hit that was the other part of the first part of the
Oh.
question, now I forgot, sorry.
Oh, I'm sorry, it was, is that a major issue in rural hospitals, the EMTALA and a lot of the.
It is for every
Yeah.
hospital, I mean, and again, I talked about there are plenty of, you know, what you are probably undocumented workers, whether it's in agriculture or other light manufacturing that might happen in rural areas. And again, you come and present to the ER, they're not asking about your immigration status. They're going to stabilize you, and that's just the requirement of being a operating hospital.
Jason, I have a question here for you. And maybe you don't know the answer yet, but perhaps you can speculate. How do the increases in the healthcare insurance premiums that will occur now with the ACA tax subsidies disappearing, how will they compare with increases in other insurance, in the private insurance and employer covered insurance?
Well, I'm supposed to get any day now, the health insurance premiums for the Wisconsin Policy Forum, so I'm waiting to see what our private health insurance looks like this year as I make my budget for 2026. Again, I think, you know, one of the key questions, and the other two panelists could speak to this, but it's, you know, to what degree are there secondary impacts of this, you know, of people losing coverage, of the system, you know, having to add more uncompensated or uninsured care. And, you know, I mean, it kind of remains to be seen. You know, some of this may also, again, as we talked about, some people may find other forms of sort of catastrophic coverage that will, you know, not be anything near as favorable as what they have, you know, under the Affordable Care Act plans. Not that those are also perfect by any means. So, you know, I mean, I think some of these things, it remains to be seen in the sense that, you know, we don't know, for instance, what the Medicaid enrollment losses will be exactly. We don't know what the Affordable Care Act exchange and enrollment losses will be exactly. We don't know then what the secondary effects of those things, the first things that we don't know will be. So I mean, it really is, I think, something that we're, you know, it's an experiment that we're running here.
One quick question and then a final wrap up of the three of you. Is it fair to say that if we had national health care, everybody would have a stake in making it work well? Putting you on the spot.
Well, I mean, I can start. I mean, I do think one of the drivers of cost is health. You know, in the sense that, you know, one of the ways we control costs is by, you know, doing the hard and time consuming work of, you know, getting people to exercise more, have a better diet, you know, stop smoking or smoke less, all these things. You know, one of the challenges for private coverage when, you know, we're still in a system where a very large percentage of those who are covered through private insurance. And the private insurer does not necessarily have a incentive to make a 20-year investment in someone's health and their, you know, sort of overall conditions. So that's, you know, that's one aspect to it. There may be in certain cases some economies of scale that you get within the private system. At the same time, you also have some profit motive that is obviously there and an impact. I mean, I think the last thing that I would say though, that is important to understand is at some level, we do not have the ability as a society to provide infinite care or to provide all the care that people may need. So even in a public healthcare system like Canada or Great Britain, there's still forms of rationing of care that have to take place. Those may be by just having, you know, a certain number of MRI machines and a certain number of people that needs MRIs, and there's only so much throughput you have for those machines, and so you gotta wait. to use them. So, you know, we're always gonna be paying the piper in some ways. You know, is our current system the very best one that man, man or woman could devise? No, probably not. So, I mean, I think certainly there's room for improvement. And for me, always the biggest thing is, can we make people healthier? Because at the end of the day, what we don't want is to have coverage and with all due respect, pay healthcare providers. What we want to have is good health. And we certainly need providers as a part of that, but it goes well beyond that as well.
We are right at the end of our forum, but I'm just going to give you each, 30 seconds or less just to go through the three of you. And what are you, from your professional perspective, what are you hoping for or projecting will happen in the near future?
Well, thank you, and thank you to the League of Women Voters for having me. I just will tack on a little bit on that last question. I mean, we have seen an average payer mix for a Wisconsin hospital with Medicare growing. This is from 2016 to 2024, Medicare growing from 45% to 55%, while the commercial shrunk from 37% down to 28%. So in some sense, we are seeing more of like a universal health care, because again, once you turn 65, you can get onto Medicare. I think when I'll be 67, I'll be eligible, but so I do think there's a lot that are stressors definitely on rural healthcare. Payment mix is obviously one, workforce is definitely another. And I know all my members are doing what they feel is the best for their community and working within their community and even broader service area. So I think those stressors aren't going away, unfortunately. And as we look forward, yeah, we can all do a little bit more to get healthier, but making sure those access points are there for those of us that don't live. I mean, I can walk to 4 different hospitals within 15 minutes if I wanted to. So that doesn't, that needs to be considered as the access and what that may cost.
And stress isn't good for our health.
Shiva, stress definitely not good for your health. I think I will kind of tag it into the last question, which is, for me, what we need is quality, affordable healthcare. Certainly we need good health, but we are going to need healthcare. So quality, affordable healthcare. What that system, like, I just don't like labels, like national healthcare system. The devil is in the details. All of these things, the devil is always in the details. So when we say national healthcare system, what do we exactly mean, and who gets to decide on behalf of whom? I think we've seen it in many places and many countries. Most other countries have some form of a national healthcare system, but arguably they all still have some issues. So I would say that, and then from my perspective, I think we need to continue to really understand the impacts of healthcare costs and overall quality of life and socioeconomic abilities of families, and understand that all of these policies have disparate impact. They will impact communities that have always been traditionally more impacted by any of these policy more than any other. And those would be, again, certainly based on racial, ethnic groups and other identities, rural and socioeconomic. So really always thinking about what is the intent here, who's going to still be able to have access and who's going to be left out. And then last piece I would say is, Jason was talking, we don't know what we don't know, because some of these things the money we can talk about and say, okay, that's how much it's going to cost. I'm going to see the impact immediately, but the long-term impact on health and healthcare of people, that we're not going to see for a bit, right? Just the same way that since Affordable Care Act passed, we're now starting to see what the impact was of having a much higher number of insured people and access to healthcare, and how it improved the health of entire populations. So it may take a while until we actually see the real impact.
I'll be very quick. A real Wisconsin Policy Forum centric wish. I hope that we continue to get good data about what's happening with the system. I mean, during the government shutdown, we've had to put out reports without the same information that we would have had otherwise, because we don't have access to it. So I hope that we'll have good, reliable information from federal sources going forward that we can share with all of you in the years to come.
And hopefully we have wise minds prevailing and making the decisions ahead of us. So we must come to a close now with our forum. It's gone by very, very quickly. But I hope that you have been enlightened by some of what has been shared this evening on healthcare going forward in Dane County and Wisconsin. Before we conclude, I want to thank the League's Healthcare Forum Work Group, including Ann Lacey, Janine Ramsey, and Rebecca Denai, our chair, Martha Stackle, and all of the behind-the-scenes volunteers who have been helping this evening. Also, thanks to our videographer, Jonathan Steffen, who made it possible for us to be together both virtually and in person tonight. And a video recording of this forum will be available on the League of Women Voters of Dane County website. Thank you again to our expert speakers, Jason Stein, president of the Wisconsin Policy Forum, Shiva Badar, co-chair of the Latino Health Council of Dane County, and Jeremy Levin, director of advocacy at the Rural Wisconsin Health Cooperative. If you're interested in signing up for the post-forum discussion this Thursday, November 6th, from 7 to 8:30 p.m. via Zoom, just scan the QR code or go to the LWVDaneCounty.org website. Additional information on the critical issue of healthcare going forward can be found in the resource guide, which is also on the website. So on behalf of the League of Women Voters of Dane County, thank you all for attending this forum this evening. Remember, your vote is your voice in our democracy. So never pass up an opportunity to use it. Thank you. Good evening.